everybody. Thank you very much for, I see the participant numbers going up, so I think we're doing it right. We're a couple minutes early, so we just wanted to let everyone into the meeting room. Thank you all for being there. There's a huge lot of us on tonight, so I appreciate your patience. There's nothing that gets my heart rate going than having to send a new URL to register just before. So appreciate your patience. We're very thankful to have you guys here and making the time to join us for this webinar. It's unprecedented times, of course, as we all know, and we're in the thick of it still, and we're very appreciative to have Dr. Langtree, who is a close friend of the Foundation's, offer his time up to go through this webinar this evening. As we've publicized, and as you've probably seen on social media, there is an opportunity for questions to be asked. You can ask them in the Q&A box within the Zoom app. We'll be taking those at the end. We have allotted, the end of the presentation for questions and answers, but I imagine we may run a little bit late after 8 o'clock if there are substantial questions. We have about 300 people joining us tonight, which is absolutely incredible. Attendees from all over the world, actually. We have about 24 from England, some Germany attendees, and Australia as well. So good morning, good afternoon, and good night, I guess. Leading up to that then, before we throw it over to Dr. Langtree, I'll just read his bio for those that aren't familiar with him. Dr. Langtree is a kidney doctor and scientist who is studying nephrology, genetics with special expertise in polycystic kidney disease at St. Joseph's Healthcare Hamilton and McMaster University. Dr. Langtree is supported by the Canadian Institute of Health Research, the Canadian and American Societies of Nephrology, the Kidney Foundation of Canada, and Crescent, their National Kidney Scientist Training Program. Dr. Langtree has published over 60 articles in high-impact journals in genetics and medicine. Dr. Langtree has set his goal to use studies of our DNA to improve the care of patients with kidney disease. Dr. Langtree is a wonderful friend, as I mentioned, of the Foundation. He's yet to say no when we've put out an ask for him. So on behalf of myself and the PKD community and those in attendance, I thank you, Matt, for joining us tonight, and I'll let you take it away.
Well, and right on time, too. So, and thank you everyone for your interest and for coming tonight and joining to talk about polycystic kidney disease in the era of COVID-19. Jeff, there's no concerns about muting or anything like that we need to worry about, and shouldn't be a problem. And yeah, I guess if there's one silver lining of COVID-19, maybe off the top to say, is that, it does afford us these opportunities to, video conference and Zoom meetings and everything, kind of in a way makes the world seem a little bit smaller. So yeah, so tonight, before I go on, I just want to show here my disclosures that I have received speaker and advisory board fees from Otsuka. And as you heard, I have research support and salary support from the Canadian Institute of Health Research and Canadian Society of Nephrology, American Society of Nephrology, and the Canadian Kidney Foundation. So the goals that I've really set for tonight is to talk a bit about the effects of COVID-19 on people with polycystic kidney disease. What should I do if I have polycystic kidney disease in the era of COVID-19? If I actually get COVID-19, and kind of go through, and then hopefully we'll have lots of time for questions if anyone wants me to delve any deeper in any area in particular. I am going to start with a bit of an overview. I'm sure most people here have kept up to date with the news and have read lots of the media and even delved into the research. But I'm going to start off as well with a little bit of a background. So coronavirus disease 2019, or COVID-19, is a respiratory virus. It's named after, so corona is Latin for crown, and it's named after the spike projections on the outside of the virus. The corona is also the atmosphere of the sun around the outside, which also has this appearance of this spiky or fuzzy kind of outside, and even Corona knows their Latin in the marketing of their beer. The symptoms for coronavirus, it's important to know that not everybody has all of the symptoms. So, in fact, many people are asymptomatic, even though they're infected. But symptoms are classically a fever of over 38.5, cough, shortness of breath, sore throat, non-specific abdominal pain, and gastrointestinal symptoms, including nausea, vomiting, and diarrhea. And then there's kind of some odd kind of features too that have been reported to people saying they have odd taste or odd smell. There's changes even in their toes or fingers. And then there's a pediatric constellation that's also been reported with kids because of an active immune system in the context of the infection. The median incubation time is usually about 5 days. So that's from time to exposure to the virus to symptom onset is on average 5 days, but can range from 2 up to 14 days, which is where the guidelines or the directives to try and quarantine for 2 weeks after travel or after any possible exposure. And again, an important underlying thing here is that asymptomatic spread is possible. This is something that was debated early in the pandemic, but it was recognized that there's many people that are asymptomatic and yet still have high enough viral loads and enough viral shedding to actually cause infections in other people. So coronavirus is transmitted via particles in secretions, typically oral secretions from coughing, sneezing, but also things like breathing, speaking, singing, and eating. These particles generally fall fairly quickly as they're large particles, which has led to the physical distancing guidelines. There is concern with aerosols, so smaller particles, especially in the context of aerosol generating medical procedures, which I'll talk a little bit about later. Testing is very important, but it's also been a challenge for the field as a whole. There are different types of tests for COVID-19. So the most commonly used test now is a test for the genes of the virus within the infected person. Problems with it is that it takes a little bit more time for this kind of test, and it still remains relatively expensive. That's why people have been trying to develop antigen-based testing. These would be lower in cost and much faster turnover, but are not yet really approved for general use. And
sorry to interrupt there, Matt.
Yeah.
I've had a request that you turn your video back on just for those that have hard of hearing.
Oh, I thought my video was on.
I can see it.
See me?
I can see it, yes, but an individual just said if you could turn it back on slightly better for those with hearing impairment.
I wonder, are there others that can maybe send messages that they can see me if they can see me? Because as far as I know, my video is on. No,
someone else just said, Matt, we're getting a bit of a mix. Most can see you. Some say that it's just your name. Some say they can see fine. So what I believe is actually happening is there is a preference on the panel that you can actually minimize it, or you can open it to both of our views smaller, or just you, Matt. So I think everyone just needs to change their personal viewing preference to show the speaker as well. So I think we're okay to carry on, Matt, and hopefully that will resolve the issue.
Okay. So yeah, please interrupt anytime too if people are having concerns in any way. So we've talked about most of the testing is looking for the genes of the virus. The the kind of next generation of tests, which are still under development, is looking for parts of the virus. And then the last, also still in development really, are the antibody type testing. And this is the kind of test that can test if you've ever been infected in the past and whether your body has started to develop an immunity or antibodies against the infection. An important underlying thing is that the severity of infection is largely proportional to the age of the person who's infected. And this has really led to a lot of the problems that we've seen in long-term care facilities and in elderly populations. As well, there's concern that those with comorbid conditions or other diseases, whether it's chronic kidney disease, chronic lung disease, liver disease, heart disease, diabetes, obesity, or those who are immunocompromised, are at a higher risk of getting the infection and also from having larger complications. So immunocompromised, I should say it here, so that really refers to people who are on immune modulating treatments for autoimmune conditions, for those that are on chemotherapy for cancer, those who are post-transplant, which is obviously very important in our community, and as well as people with infections like HIV. But really, this kind of statement has generated a lot of fear because it's hard for people to know really their risk, to quantify the risk if you have any of these conditions. And certainly there's a huge portion of our population that has one of these kind of conditions. So I'm going to try and delve into that a little bit too. So these are the numbers, the Canadian numbers that have shown the growth of COVID-19. We're at about 90,000 cases and 7,000 deaths in Canada. Cases are primarily clustered in Ontario and Quebec, despite an early outbreak in British Columbia that was very well controlled. Currently, however, there's only 59 cases in hospital in Hamilton right now. And there's certainly reason for optimism. As you can see that there's been a peak and the number of new cases daily has been dropping for some time and has been under the 1,000 mark for Canada for a couple of weeks and continues to decline. The deaths is falling a little bit behind. It takes 2 weeks usually for those that do pass away from the infection to do so after the new diagnosis. But certainly we're seeing declines in both new cases and in deaths. A further reason for optimism is that it's quite likely that a larger percentage of our population has already had COVID-19 than was recognized. And this was largely due to the challenges of testing and getting testing. And why this is optimism is that it means that the case fatality rate, so that's the number of people who pass away out of the people who actually get infected, is probably much lower than originally predicted if more people are actually having it and having asymptomatic disease. And of course, it's quite likely that this virus is going to move into what we call an endemic virus, meaning that it's going to be in our population. Same time, I think we're still a long way from herd immunity, and most optimistic estimates are that 10% of our population have had COVID-19, and so that's the most optimistic. So we're still a long way from herd immunity. This is actually European data, and so it's the average number of total deaths per week, and so you can see deaths in those over age 65 are higher in the winter months due to influenza. And this is total deaths. So each of these lines is each of the previous 10 years. So you can see there is a large surplus in deaths attributable to COVID in 2020. And if you look at the younger age group, so instead of over 65, 45 to 65, 15 to 45, you can see there's still an increase in number of deaths until you get down into children. And because children, while they are able to get the infection, they're less symptomatic, and it's very uncommon, very, very uncommon for children to succumb to COVID-19. You don't see an increase in number of deaths there. So an important message, so this is actually American data, but you can see the background average weekly death rate and the increase in deaths attributable to COVID-19. An interesting thing here, a sad thing, is that there's also an increase in deaths not attributable to COVID-19. And so this really takes me to one of the first take-home points, and it should really be that we need to not be afraid to go to hospital and seek out care if it's required. There are lots of people that are presenting to hospital with advanced stages of diseases that could have been treated because they were afraid. And so it's really important that we, emphasize the importance of still seeking care if it's required and making sure that we're treating other diseases as well as COVID-19. Who should get tested for COVID-19? This is the Ontario guidelines that were released fairly recently, that any single COVID-19 symptom or a contact with a confirmed case or a patient arriving at a hospital or congregant living arrangement, so long-term care facility, group home, or correctional facility. These are the people who should be getting tested, and even we're testing more and more people. So it's really getting almost to the point that anybody can get a COVID-19 test should they try to seek it. It's important that the testing is going to be less effective and more likely to have false positives in people who are asymptomatic or if they have not had a clear contact with a confirmed case. And really, it's not going to change management. It just can help to reinforce the need for quarantining and physical distancing. If we're all doing that in the first place, then it mitigates the need in testing those who are asymptomatic. So in the context of polycystic kidney disease, I expect most of the people on the call here are familiar with the natural history of polycystic kidney disease. And I really put this here to emphasize that the ramifications of COVID-19 vary with your underlying disease severity and age and other conditions that are affecting you. So clearly people in their 30s or 40s who have multiple cysts in their kidney, but they still have normal kidney function, are different than those who have developed kidney failure requiring either dialysis or kidney transplant. So first off, I'm going to talk about what is good for everybody. And realistically, this can be extended beyond just people with PKD to anybody. So of course, we've heard about physical distancing and keeping a safe distance of 6 feet. And so really everyone's personal space has to grow a little bit. Hand washing we have to be conscious of hand washing more than we think is reasonable. So this isn't just when you get home or just when you go out. It's, really being conscious of washing our hands, as frequently as possible, realistically. It's never a bad time to quit smoking, and certainly smoking's bad in the context of COVID, but bad for everybody. So if you are a smoker, now's as good time as ever to quit. This is something that was really debated earlier in the pandemic, and really there's been a consensus now that masks are good for everyone, unless you're trying to eat ice cream. These are actually my children. But there's a recent paper by one of the doctors here in Hamilton in the Annals of Internal Medicine that really points to that the point is that any mask is able to keep some particles in. So even if it's not 100% effective at preventing other particles from coming in, it prevents you from spreading out your particles. And so really the plea is to a sense of duty to try to help others. So wearing your mask, you're really doing it to try and help those around you as much as you're doing it to help yourself. There was concern about unintended consequences of generalized masking in everybody, including the possibility of improper use, and so touching the face when putting the mask on and off, a false sense of security that potentially people wouldn't socially distance, or they'd be not as diligent with their hand hygiene, or potentially that people would be seeking out surgical masks or N95 masks and having them not available for those in higher risk environments. Really, all of these, I think, and the message of this paper is that they can be mitigated with education and social pressure. And so even cloth masks are a great idea. This is a bit of a joke. It's an internet meme that maybe some of you have come across, which is potentially a touch crude, but how your pants, you know, I can leave it for a second and you guys can maybe read the message, but the idea is that while the pants may prevent someone else's pee to get on you, it's really to prevent your pee from getting on others. Maybe this is more applicable because I have young children, but I thought it was quite comical. So despite these kind of messages, survey data across the world has shown that lots of people are still skeptical about the benefits. Lots of people have anxiety or feel uncomfortable wearing masks. It does take an adjustment, but you know, surgeons and nurses have been wearing masks for extended period of time for decades or longer. It is an adjustment, and I don't mean to diminish it, but at the same time, I think it's important. It's an important thing to do during this time. A common question is what type of mask? So these N95 masks are the ones that are important in the context of those aerosol generating medical procedures. So you'll see medical professionals wearing them, but really surgical masks or really even cloth masks, as I was saying, are sufficient in the vast majority of contexts. I would say, so masks that have vents on them, like this, or N95s that are vented, should be avoided, because these, while they provide protection for air going in for the wearer, they intentionally vent out any of the droplets, so they provide no protection for others. So it's important that we stay away from vented masks. And then social distancing and being outside. We know that over distance, heat, humidity, sunlight, wind, all reduces the chance of exposure to the virus. And so spending time outside is a great idea at this time, getting exercise. People have asked about swimming. For sure, the pool water, the chlorine or bromine in the pool or spa water will kill the virus. That said, the challenges are that wearing masks is difficult or impossible in the water, and social distancing, especially among children, can be very difficult. And so while swimming is safe if we're keeping distant, we need to be really diligent in keeping in mind the concerns as well that can go with, you know, the attracting of multiple people into smaller spaces. And of course, while being outside is a good idea, some maybe saw in the news what was going on in Trinity Bellwood Park in Toronto, and I sympathize with these people that many of them were cooped up and don't have appropriate access to outdoor space. But certainly we want to avoid congregating in large groups. And, you know, being cognizant of don't being a super spreader. This is showing, you know, the transmissibility of the virus. So this was actually a choir practice where people are expelling droplets as they're singing. And it is possible for one person coming in to spread to dozens, literally dozens of people in the bright context. So avoiding these situations and not being the red one here. So one bit that is going to change for people with all conditions, but especially those with PKD, is going to be, all of my clinics have essentially changed over to virtual visits, at least in the near future. One thing I would like to ask is that everybody takes the time to prepare for their visit. And I think the act of getting ready and driving to the hospital or driving to the doctor's office gives people time to prepare. And so sometimes there's set back when I call them at home. And so making sure that you have your medication bottles or your blister packs out, that you have a log of your symptoms. And so it's not when I ask you, you know, oh, have you had any pain or blood in your pee? like trying to think about how you are before the visit is a great idea. Trying to have logs of your weight and blood pressure and heart rate is very helpful. Trying to have handy the names of the other doctors that you see. Being cognizant of getting the blood work before the appointments is a huge help. Many people have been afraid to go get blood work, so I would encourage you to set appointments for socially distant opportunities to get blood work. Certainly, we want to try and mitigate and reduce the need of not unnecessary testing. And if you have a question about whether something is required or not, by all means, be in contact with the ordering physician. But try to get it done where it's needed in advance. Be ready to speakerphone with caregivers and family members. Traditionally, if multiple people were coming to the appointment, it's good for all of those people to be involved, even if it's a virtual visit. So this may mean, downloading software in advance. Certainly in Hamilton here at St. Joe's, we're using My Dovetail, which allows virtual visits, which includes a screen, so for video conferencing. So, trying to be set up in advance. And the last thing I would say is that no caller ID is a great idea for avoiding telemarketers, and it's fairly regular that people call from the hospital and people don't answer the phone because it's a no caller ID. So really being mindful, especially if you're expecting a call for an appointment, that a call may come from no caller ID. And really, the hospitals should be switching around to be identified, I think, instead of coming as no caller ID, but that's the current state we're in. So more important than the Fitbit, in my mind, the Fitbit may be exciting, and wearable technologies are certainly a field for research and exciting, but I think at this time it's really important that everybody has at home a scale and is able to keep an eye on their weight, especially if they're on diuretic type medications. Having a blood pressure cuff that they know how to use and has been fit for them, and having an instant read or a digital thermometer. If we have symptoms, it can be very helpful to quantify a fever, and if you don't have a thermometer, it makes it difficult to do. Blood pressure monitoring at home. Previously, people would go and, we have the True BP machines that measure multiple times. But at this time, it's really important that people, once or twice a week, it doesn't have to be all the time. Ideally, you're an hour from coffee or smoking, 2 hours from food, at least 5 minutes, totally relaxed, watching TV. You want to be seated, both feet flat on the floor. Take your blood pressure once, throw it out, take it again and again and again, and keep track of the best number you can get the blood pressure up to give you. Don't round, write down exactly what it's giving. And I encourage people to keep track in a log on their phone is probably the simplest way to do it. The paper works well too. So for those with normal kidney function, there's really no reason to think that you're immune compromised in any way. The medications that we treat early polycystic kidney disease, even if it's an aggressive form, really shouldn't change your infection rate or the rate of complications from COVID-19. So hopefully this is reassuring to people, and really standard precautions are all that are required. Many people are on ACE inhibitors or angiotensin-receptor blockers, ARBs, so you'll recognize that in your medication list. The prils, so captopril, enalapril, ramipril, perindopril are ACE inhibitors, and the ARTINs are candesartan, irbesartan are the ARBs. There was initially some theoretical concerns that potentially these medications could increase the risk of getting COVID-19. This is because ACE2 right here, which is the angiotensin-converting enzyme 2, actually acts as a receptor. It's found in the kidney and our hearts and blood vessels, but it's also found on the lung cells. And this ACE2, the virus, utilizes this receptor to gain entry into our cells. And ACE inhibitors have a side effect in that they actually increase the number of these ACE2 receptors on cells. So the concern was, if we're on these medications, could it increase the number of receptors and lead to an increased rate of infection? But then we also know that the ACE pathway can also lead to increased inflammation. So then people are saying, well, maybe actually these are therapeutic and could lead to better outcomes in people. So really there was a lot of argument about the pathophysiology, how these things work, to try and figure out whether we thought they'd be associated with an increase or a decrease in risk in COVID-19. And so before I go on with the story, I just want to have one little tangent about something called preprints. And you might have heard of them in the media. These are late-breaking scientific papers, which I think play an important role in the rapid dissemination of knowledge, but they come with a concern because they have not undergone peer review. And so they do not have the same quality control as published research. And so they could contain errors. It's very easy for them to be misinterpreted, and they're often inappropriately communicated in the media. So anytime you see something that is from either of these, bioRxiv or medRxiv, or it's reported as from a preprint, I think you really need to take it with a grain of salt. And even if it's given in the context of a trusted physician or a trusted source, even high profile newspapers and make reference. But if it's from a preprint, I encourage you to really take it with a grain of salt. So going back to this ACE, ARB, and COVID-19 story, there was actually 5 papers in the New England Journal of Medicine, one of the biggest journals, within the last 2 months looking at this question. And curiously, one of these already is on the verge of being retracted due to concerns of scientific errors. But that said, the take-home point of these articles was that they did not support that there was an association with either an increased infection risk or worse disease severity or higher mortality of those in hospital taking ACE or ARBs. And so all of the guidelines across the world, really from the European, Australian, American, and Canadian sources, have really suggested that we continue to treat people with ACE inhibitors or ARBs, regardless of COVID-19, if they've been indicated before now. As for tolvaptan, patients with PKD on tolvaptan, there's no reason to suspect that you're a higher infection risk or any at a risk of more severe infections because you're on tolvaptan. That said, we know that you have to go to the bathroom more often, and so restroom planning can be challenging. It's important just to make sure that if you are using public restrooms, face masks, hand washing. That's the most important things we can do. And due to concerns about getting blood work, Origin has a program specifically to have healthcare workers come to the home to provide home blood work draws. So that is a great resource to those on tolvaptan. Additionally, there have been delays to non-emergent procedures. People have probably heard of this in the news. In the context of polycystic kidney disease, this may mean that MRIs for risk stratification of either kidneys or head, things like cyst sclerotherapy treatments have been delayed. Hernia repairs would be delayed. Fistulas and peritoneal dialysis tubes, we've been lucky here locally that they have pretty much proceeded despite or in spite of COVID, but certainly some may have access gaining those procedures. And living and deceased donor kidney transplantation, I'll talk about a little bit later in the presentation. Currently, we're not doing living kidney transplantations. We have restarted our deceased donor program and have had some procedures going on, but certainly this is something that's high in flux and changing rapidly as we're moving through the phases of reopening. What if you think you have COVID-19? Important thing is to isolate. especially from loved ones. Rest, Tylenol is safe for fever control and aches and pains. Fluids, certainly, as I said, seeking help if it's required. So if you're short of breath, confused, have a low blood pressure, or unable to care for yourself, go get help. Caregivers should be using personal protective equipment. So, minimally masks, ideally gloves and gowns or changing of clothes, minimizing contact. And ideally, the sick person should also be wearing a mask to prevent transmitting the virus out. As there was, I would add here, there was some discussion as well early about risks associated with Advil or ibuprofen, Motrin, naproxen in the context of COVID-19. In those without any comorbidities, it does seem like they may be a safe choice, but generally speaking, those with any kidney, we generally try to avoid those kind of medications, anyone with any kidney abnormalities. It's important to think about sick day planning, and I encourage you, if you have questions about sick day planning, that you review your medication list with your nephrologist. Certainly, if you're too unwell to get out of bed, if you have gastrointestinal symptoms, if you're having trouble eating and drinking, tolvaptan and ACE and ARBs should be held until you're feeling yourself again. These medications are to try to help over the long term, and they can be detrimental in the short term, especially in the context of illness. Similarly, diuretics should be held if you're not able to drink. But I would say, especially in those that have underlying heart conditions, that they keep track of their weights if able, and again, be in contact with healthcare providers if they have any concerns. Those with diabetes should be holding metformin and SGLT2 inhibitors. But pardon me, again, I would be encouraging you to discuss your sick day planning with your medication specifically. And again, this is in the context of this isn't just like a bit of a runny nose or something, but this is really in the context of being too unwell to really get out of bed, or if your blood pressure is low, or you're unable to eat or drink or go to the bathroom normally. This is a complicated slide that I'm not going to get into, but just to discuss that COVID-19 itself can cause kidney injury through multiple different mechanisms. So even those with normal kidney function can get impairment in their kidney function, and certainly I am not aware of any published case studies of people with polycystic kidney disease specifically infected with COVID-19, but certainly they would be at risk of developing acute kidney injury similar to anybody else. Treatments for COVID-19, well, some world leaders have suggested they had an inside track on therapies. Really everything that is under investigation is still in the scope of clinical trials. The best treatments are conservative therapies that we can give in hospital. There's no role for prophylaxis. There's no role for treatment for people who are well enough to be at home. I would say to beware of phony claims. People are taking advantage of the fear in the situation. So from silver or ultraviolet light or garlic supplements, antibiotic use, or excessive nasal clearing. There's no role for any of these. Vitamin D is perhaps the most controversial, and I can address that if people have questions, but really I would only recommend standard vitamin D dosing if you are inclined in taking that at baseline. Data out of how people do in the intensive care unit in Canada. This is a published case series from Vancouver, where 117 people who were sick enough with COVID-19 to be admitted to the intensive care unit. The mean age was 69, a third female. You can see 12% of them had underlying chronic kidney disease. They didn't specify what the cause of their chronic kidney disease was, but realistically, this isn't that far off of the prevalence of kidney disease in the general population of 69-year-olds. So, while kidney disease may be a slight risk for worse infections with COVID-19, it's certainly not a very large effect anywhere near the effect of advanced age. 2/3 of people needed a ventilator who were in the intensive care unit. Those who received care with a ventilator required it for an average of 14 days. But an important take-home message was that people in the intensive care units in Canada did much better than people in intensive care units in other places, such as Seattle, New York, and Italy. And this has a lot to do with the flattening of the curve. The fact that we did not have overwhelming of our systems from nurses, physicians, respiratory therapies. We had no shortages and really we could provide optimal care. And so only 15% of those admitted to the intensive care unit died of their condition, and 60% were discharged home. Of those on dialysis, this would be true for anyone on dialysis, not just polycystic kidney disease, but certainly of those with PKD who are treated with dialysis, there is a risk of exposure within dialysis units, and this is just because it necessitates people leaving their home isolation and coming together. Certainly transportation can be an issue too if you're going back and forth in public transit or shared transit. It's unclear actually if there's a higher mortality rate in patients on dialysis, which is curious, and there are some hypotheses why people think that might be. But certainly home dialysis modalities such as peritoneal dialysis is the best option because there isn't that travel, there isn't the going to the hospital 3 times a week. So, seeking out if that's an option, but certainly missing dialysis is a bad idea. Of those who have had bad outcomes with COVID-19 on dialysis, many of them it's because they were too unwell to go to their dialysis, and yet they were too afraid to go to the hospital. So, it's really important, even if you become unwell, that, you're in contact with your dialysis unit or your hospital, and, missing dialysis isn't an option, just even if you have a COVID-19 infection. And certainly there's more resources available through the Kidney Foundation at kidney.ca. So this is just a nice infographic that really summarizes for those with polycystic kidney disease on dialysis, the importance of hand hygiene, isolation, avoiding public transit and wearing a mask, hand sanitizers, distancing, and wearing a mask during your dialysis session. We've tried very hard here in Hamilton to have separate units, so certainly if people are COVID positive, they're kept in a totally different area than people who are getting dialysis who are not. We're distancing people as much as possible and using our isolation rooms as much as possible. So certainly it's been a challenge, but I really think we've done an admirable job handling the challenges. Kidney transplant during COVID-19, as I said, there have not been any new living donor transplants. Deceased donor transplants have started to come up because those organs would otherwise go to waste if we were unable to utilize them. It's important if you have a kidney transplant that you do not change your medications without speaking to your transplant nephrologist. Certainly, there's no role for any prophylactic treatment to try to prevent COVID infection. We do presume there's a higher risk of infection given the immune suppression that's required to prevent organ rejection. That said, really it's watching for the same symptoms and using the same general precautions that are true for everybody. Certainly, if it's feasible to avoid any public spaces, you can try to do that. At some point, I think this virus, though, is going to be endemic in our society, and it is going to become, people are going to have to make some balancing between risk of exposure and getting back to life. Importantly, if you are unwell, seek help, and I hope that's kind of been an underlying message of my talk tonight. Something that's hard to discuss and scary to bring up anytime, and especially in the context of COVID-19, is advanced directives or end-of-life planning. I think it's important to put this in the framework of how do you see your death to happen, because along with taxes, there's only one thing I'm sure of, and that's that we will all pass away at some point. So having some kind of idea of what you see as a good death, and you know, if and when it happens, that, you know, there's a plan in place. Certainly there is a toll involved in intensive care. So in the picture here, you can see this is a renal replacement machine, and these are infusion pumps supplying medications to help support the blood pressure and control the heart rate. And back here is the ventilator that's replacing the lung function. So, but this all comes with discomfort and suffering, and, you know, recognizing, while we have had excellent outcomes in the intensive care units in Canada, it is still, you know, heroic measures. And they picture their end of their life if they're in these kind of catastrophic situations. And the only study that I've come across that looked at resuscitation outcomes in patients who are COVID-19 positive, they have been fairly dire. So only 3% of, so 1 in 136 people who required CPR who were COVID positive survived 30 days. And so again, this needs to be considered when thinking about, you know, how, you know, what kind of toll you want to take going through that resuscitation process. If in all likelihood it may be unsuccessful in the long run. Finally, maybe a more positive thing is to think about a vaccine that could, you know, has really been promised as the hope to end COVID-19. There has been really an enormous output, billions of dollars spent on the development of a COVID-19 vaccine. And I don't know if there's anything that humans have spent so much time and effort on that hasn't been fruitful in the end. So I am confident that in time, we will be successful in developing a vaccine. That said, patience is going to be required. And I personally think it's going to be very unlikely that there's a clinically validated and safe and ready for prime time vaccine before 2022. I think that we will require randomized controlled trials where we're vaccinating some people and giving placebo to other people to see if there's differences in both preventing COVID infections and preventing mortality associated with COVID infections. I think that there's going to be a need to adjust to the new normal of COVID-19. The handshake being dead, and I think you know, we are going to have to transition to a state where we do all of the preventative measures that we can. So physical distancing, you know, masking, hand washing, being very cognizant of our health and staying away from others if we're feeling unwell. And this too will pass. Eventually it will be a, you know, something that we have figured out mitigating strategies to deal with. So with that, I want to give my take-home points. So do stay distant, do wash your hands, do wear a mask, especially in public. And it's for the safety of others as much as for the safety of ourselves. Don't be afraid to seek help if you need it. We are working very hard to try and make our hospitals as safe as possible, and you know, avoiding care can lead to other problems. I ask to please be prepared for virtual visits as much as possible, and be prepared. I don't think, again, virtual visits, I think the way that we practice medicine is going to change, and there is going to be less waiting rooms. There's going to be less physical contact, but there's going to be more virtual visits. Don't worry about it if you read in the media that there's concerns about ACE inhibitors or ARBs in COVID. If you're required tolvaptan, I would encourage you to continue taking it while being cognizant about sick day rules. So both with your ACE inhibitors and your tolvaptan. And so with that, I'd happy to take any questions. And thanks again for having me.